Hopefully we'll get a bunch of young people who will always remember Barcelona.
Yeah, that's right.
Thank you. With Paul Blank.
Yeah, Caleb.
Nice to meet you. Nice to talk to you guys.
Welcome, everyone. My name's Dave Mesko, CEO of the Ia Slc. It's a pleasure to welcome all of you to our first press conference of the 2019 World Conference on Lung Cancer. It's our 20th WCLC. And I'm delighted to just share with this smaller audience right now, but our registration numbers are approaching 7,700, which is a record for us, which we're very excited about. And we're represented right now from 107 different countries here at the WCLC, which is also a high water mark for us. So we're very excited about that. I think what that is a testament to is clearly the interest in lung cancer and other thoracic malignancies. And it certainly speaks to the quality of the program and the interest and also the quality of the speakers that we have here, not only today, but at our other press conferences and throughout the conference. So I invite all of you to come to all of our press conferences, as we'll be talking about and highlighting all of the interesting developments that are going on over the next several days. I guess just one ground rule before we jump into it, I would just ask that we hold questions until the very end, and then we're going to open it up to all of our panelists to take your questions. But with that, welcome to our panelists, and to kick us off, I'd like to invite Dr. Rami Porter and Dr. Rizal to the podium here. They are our conference presidents. Also joined, Enriqueta Felipe is another one, but couldn't make it. But I invite you up to share some of the highlights and the interest and the excitement.
Let's see. Okay. Let's see. No, don't go. Okay. No, thank you.
Ladies and gentlemen, on behalf of Dr. Enriqueta Felipe and Tony Rizal, we would like to welcome you to Barcelona and to the 20th World Conference on Lung Cancer. We have divided the different tracks among ourselves, and Tony and I will cover Dr. Felipe's slides. We'll try to give you what we think are the highlights of this meeting. Okay, I'm sorry. It works now. Maybe here. Nothing to declare. Here. Okay. Regarding the treatment of early-stage lung cancer, there will be 2 randomized clinical trials comparing the minimally invasive approach with a classic thoracotomy. Now, these are important studies because we have been practicing VATS resections, video-assisted thoracoscopic resections, for at least 2 decades without a proper study, with properly designed clinical trials. Now we have 2. And we don't know the results of the first one, which comes from the UK. It will be presented in the presidential session. The other one comes from China. And we think that the results of these trials will change the mind of many thoracic surgeons who still are resistant to practice video-assisted thoracoscopic surgery for lobectomy to resect lung cancer. There are not so many surgical trials, so I think this is an important thing that these are presented here at the World Conference. Regarding staging, you probably know that staging is one of the pillars of the Scientific Academy of the Ia Slc. So we have been collecting data from around the world to revise and improve the TNM classification of lung cancer. That's the anatomic extent classification based on the tumor, primary tumor, lymph nodes, metastasis. And we will analyze certain aspects of the data set that we are using now to collect cases for the 9th edition, which is due to be published in 2024. And lymphadenectomy, you see here, both in the first study and the second study, is of paramount importance. We have to stage the tumors before treatment, knowing whether there are lymph nodes involved or not, but also the intraoperative assessment of the lymph nodes at lung resection is important to stage the tumor properly so that we can make therapeutic decisions after resection in terms of indication of adjuvant therapy, for example, or in terms of prognosis. The N factor gives us a shade of the prognosis. Finally, Oligo Metastasis was one of the jewels of the crown last year in Toronto. There were many presentations. The oligometastatic disease is getting more attention because now we know that if we select patients well and if we can treat radically both the primary site and the metastatic site or sites, prognosis is much better. Anything that we can obtain over a 0% mortality, which is what stage 4 has, at least the clinical staging, is an achievement. And we can achieve much more than that by applying local therapies both to the primary tumor and the metastatic sites. In the treatment in the real world, well, it's evident that not all thoracic oncologists or surgeons have the same facilities in their institutions. So these are sessions that will inform us about the difficulties that some of our colleagues have in getting patients with lung cancer in early stage, for example. My colleagues in certain countries tell us, well, we only see advanced disease, malignant pleural effusion, so that the resection rate is very low. So all this will be discussed here together with the patient-reported outcomes. You know, physicians study the disease from the scientific point of view, but it's also important to know what's the feeling of the patient regarding their illness. You know, they have different perceptions on the disease and also on the diagnostic tests and therapies. Regarding our colleagues in nursing and allied health professionals, you will see if you attend these sessions that nurses can do much more than the topic work that they do in the wards. They can really assist the oncologists and the thoracic surgeons taking care of some activities in the outpatient clinic, in follow-up, in taking care of the wounds postoperatively, and so on. I think it's really relevant that the nurses have many sessions in this conference, and also they have sessions in other tracks. Conquering thoracic cancers worldwide. Lung cancer is not the only neoplasia that is dealt with by the Ia Slc. We also have thymoma and other thoracic malignancies and mesothelioma. Now we will have presentations on novel biomarkers. Biomarkers have been studied more in lung cancer, but also in mesothelioma and thymic tumors. They are very well studied, or they are beginning to be studied better. Chest wall tumors are rare tumors, but they may pose difficult therapeutic problems. And there will be 2 sessions, one on chest tumors proper and the other one on tumors of the sternum, very rare but sometimes difficult to treat. Regarding mesothelioma, we will have novel molecular markers and a very good update on the ongoing trials on therapy. So regarding this set of tracks, first the randomized clinical trials, really important. They will change clinical practice. The relevance of the Ia Slc database for the staging project. The importance also of the nurses in cooperating with the treatment and follow-up of the patients, increase awareness of patient-reported outcomes, and also the combined therapies in all thoracic malignancies, lung cancer, thymic tumors, and mesothelioma. Disclosures from Enriqueta. Targeted therapies, also this was the jewel of the crown last year, but we are following with the topic because both targeted therapies and immunotherapies are the research lines that have changed therapy and also prognosis in advanced cases especially. We'll have the first study is a drug to treat red fusion positive lung cancers. Small percentage of the cancers have red fusion, but we have now a drug that seems to be effective to treat this lung cancer. And then we have this umbrella phase 2 trial analyzing a molecular therapy based on the type of molecular alteration that the tumors have. And then 2 studies regarding KRAS. For KRAS, there was no therapy, right? Now we start having therapies for KRAS in the form of drug, but the last study, the last line, is the chimeric antigen receptor T cells that have already been used and are already being used in hematological malignancies, and now they may be effective to treat lung cancers with KRAS mutations. Immuno-oncology, 2 trials looking at tumor TMB, tumor mutation burden, that will emphasize the importance on the outcomes on the tumor mutation burden. Also, the mutations associated with the sensitivity or resistance to immunotherapy. You know that the tumors have the capacity to become resistant both to chemotherapy, targeted therapies, but also to immunotherapy. And this trial will analyze this. And we will also have a combination of immunotherapy for subgroup of patients, patients with a poor performance status and other subgroups of patients. And finally, at the end results of the IMpower 131 that will give the final results of this study. I think this is yours, so thank you very much.
This one?
No, it was already.
Ah, okay.
Yeah, it was just following. That's the best. Yeah. 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 I do it. A bit pressure. Yeah. I'll try with this. Okay, then this second part from Dr. Philippe is on the immuno-oncology and advanced non-small cell. There are 2 abstracts that have been selected for presidential plenarium. This is a 5-year outcome, and the other is a 3-year survival. So they are really focusing on this long-term survival, and the treatment is doing well in these patients. And for the small cell carcinoma, this has been a cancer that has not been maybe much advances on it, and now we can find that this dual therapy are doing well as well. All these results are going to be discussed in the plenary session, so we don't have more information. They are embargoed. So the take-home messages is the efficacy of this new molecule for this group of patients with red fusion positive mutation. This is the National Lung Matrix trial that are stratifying patients according to the molecular the mutations. Then this is also very interesting. All the patients with the KRAS, now they have new opportunities. So also they can be very nice. For the tumor mutation burden, now it can be a biomarker, so we can select patients with immunotherapy. And also how the immunotherapy is doing well with our patients, so we have outcomes for the long-term survival. And finally, for a small cell carcinoma, there are new therapies going on. This is me. It's a disclosure for educational programs with Fujifilm and Minorini. For the first track, it's on prevention and tobacco control. I would like to highlight the communication that presents how do we have to fight the tobacco companies and not think this is a local, but it's a global problem. So we try to build global strategies to go against these companies. For advocacy, it's been focused how to reinvent clinical trials. And basically, I'm gonna highlight two. One is like to open the criteria that patients can access to clinical trials. And the other is the real world for those mutations that are not very frequent. So patients can gather together and share experience. And in this is the case for the ROS mutation. For pathology, again, we're in the area of immunotherapy, so what can be added to just the determination of PD-L1? There's all this microenvironment that is also important, so they are adding new information. And for biology, we have to think that there are other ways to treat patients. So epigenetics is an alteration that is present, so there are drugs that can be using that target. So again, we're opening the target and the treatments for those patients. For screening and early detection, there are 3 selected for the presidential conference. One of them is how to select patients so that lung screening can be more effective and select patients that are highly probable of having lung cancer. And for interventional diagnostic and pulmonology, once we have this nodule, how can we diagnose them in vivo, so using confocal? This is the first. And secondly, for those patients that can be operated or not for radiotherapy, now there are treatments that can be done bronchoscopically. So again, it's another window to receive treatments. So the take-home messages would say that, okay, tobacco industry respects the law, but it harms citizen health. So a global initiative, a political strategy is needed. Patients should have a better access to clinical trials and maybe organize themselves and maybe driven some research. Number 3, it's the immunoenvironment and the total mutation burden is important for those patients that are going to be treated with PD-L1. New targets now are explored in the epigenetic field, and lung cancer is now pushing forward very strongly, but we need to select the patients so it can be cost effective. And finally, once you have the nodule, you can diagnose and even treat it bronchoscopically. Thank you very much for your attention.
Thank you, Ramon. Thank you, Ramon and Tony, for sharing that. I'd like to invite to the podium Paul Bunn to share the highlights of the 20th WCLC.
You may wonder why I'm here. I have gray hair. I'm one of 2 people that have been to all 20 world conferences on lung cancer. Still standing. Okay, there are 4 words you need to remember. The first 2 words relate to the International Association for the Study of Lung Cancer. And those 2 words are international and multidisciplinary. The reason we're here is to take care of lung cancer, to prevent and treat lung cancer, takes many disciplines. And the organizers of this organization realized that it had to be A, international, and B, multidisciplinary. And why have we had 20 world conferences on lung cancer? 2 words, science and education. The science is unbelievable. We used to have these meetings every 3rd year. We had them every third year because that's as fast as the science came in. And for education, it's based on the science, and so every 3 years was fine. Now we have over 7,500 people here a year after the last meeting, and that's because there's so much science that you just heard about to be here. But none of us can keep up on everything. I need to have education on screening, on surgery. And so there's new science and there's education. That's why we've had 20 of these world conferences. The first, there was a planning meeting in 1972. It took 6 years from the start of planning till 1978 until they had the first World Conference on Lung Cancer. And I think maybe in the next slide, there was just over 100 people. And there have been more people attending every year since then. You can see by the second one, it went up to 1,000 participants from 38 countries, and now you heard 7,500 plus from over 100 countries. So this is what I just said: international, multidisciplinary, educational sessions, scientific sessions, social gatherings. It used to be that these meetings were 4 days, and a half of the day was for social events. And now those social events, because there's so much science, get jammed into the evenings. But still, this is where networking and collaborations occur. This is where there's interactions between all these disciplines and with patients, nurses, and so on. Of course, we have a lot of exhibits, hands-on sessions. Fellows come and learn, and they get awards. The Society recognizes people for its awards, and we also recognize why we're here, to make things better for patients and advocates. Just a quick word on that. The 5-year survival rate for stage 4 lung cancer, which is half of the patients, was 4%. Now, you're going to see with immunotherapy, the 5-year survival is, for some is 30. For those with a lower marker, it's 15. And it's over 50% for the third of patients that have a molecular driver. So what else? The first meeting in 1978. We have 4 types of lung cancer, and they're treated differently, and they have different biology. And new scientific advances in biology change the pathologic classification. There would be no pathologic classification if it wasn't for the ISLC. You heard about the staging system. In the beginning, in 1978, staging was based on 1,000 patients from MD Anderson gathered by Clifton Mountain. Now staging is done, updated every 7 or 8 years from 100,000 patients collected by the ISLC, so people can have the right diagnosis and the right stage to allow them to have the right treatment. Some of the other things, well, this is an old slide. The staging committee started in 1997, but Rami, make sure I get that right. So, advances. This is the leading cause of cancer death in men and women. Survival rates are low, but getting much better. Screening rates. We know that screening prevents and cures lung cancer patients, both men and women. And yet uptake, even in the US, is only in 4% of patients. Surgery is way better. That's, if you had lung cancer, which hopefully no one in the room will, you'd rather have 3 little teeny incisions in your chest than a foot-long incision that breaks your ribs and damages your nerves. Radiation techniques are completely different and can also cure patients with early stages. So it's really exciting. I'm happy to be here for my 20th World Conference. and I'm sure that the advances will be in your newspapers and online in the future. Thank you.
Mentioned one of the reasons why we're here, the reason why we're here is for patient and advocates, and that's a nice segue to our next group. I'd like to invite Caleb Egwenu, Upal Basu-Roy, and Brendan Stiles to the stage to talk about the IASLC STARS program. While they're pulling up slides, Caleb is our winner, Upal is the mentor, and Brendan is a thoracic surgeon.
First of all, I want to thank the ISLC for starting this pioneering program, the STARS program. And I have the honor of being one of the mentors for the program. And you'll hear from one of the mentees, Caleb, and also from Dr. Stiles, who will talk about the physician perspective on why the STARS program is so vital for lung cancer research, and specifically research advocacy. These are our disclosures. So I think Dr. Bunn set stage with this particular slide. I think we've seen a lot of progress in lung cancer research over the past 5 to 10 years. It's completely transformed. So this is just a very basic slide, and I think everyone sitting in this audience is probably very familiar with this slide. So what we did was we just mapped the number of clinical trials that have been activated over the past 30 years, and as you can see, it has dramatically increased over the past 10 to 15 years. And now we have first-line clinical trials, which we did not have a couple of years ago. Now, this progress is amazing, but at the end of the day, what we need to be thinking is how do we make this research, this progress, patient-centric? Which is what then brings me to my next slide. We, as a community, really need to bring back patient in patient-centered care. Now, what I have here is an infographic from UPATI, which is the European Patient Academy. I thought, we are in Barcelona, so, we have to thank all the work that our European colleagues have done in patient advocacy. Now, what you see is a very systematic approach to patient advocacy. And what you have below the blue box, that's traditionally what you've thought of patient advocacy, where you don't need to have a lot of experience in the science. And I think usually we think of patient advocacy as raising funding for research, but the goal of the STARS program is to sort of move patient advocates to the top category where they're actually able to participate in the research aspect of advocacy, where they have the training to sort of give the patient voice to actually making sure that study designs are patient-centric, research is meaningful to the patient community. So with that in mind, the STARS program was developed, and it was developed with the help of patients, and it's the supportive training for advocates in research and science. Now, what I have here is essentially the goals of the STARS program. First of all, to create a network, to create a community of research advocates. Now, I need to distinguish research advocates from patient advocacy, because these are advocates who are much more advanced in their advocacy journey and now want to learn the science of lung cancer, the research of lung cancer, which is essentially a second piece of the STARS program, educate patient research advocates about the science and research. And the communication piece, this is incredibly important for all research advocacy, how to communicate science. And the second piece of that is how to understand research. When we come to ISLC, when you see a presentation, what does that presentation really mean? Is it a good presentation? Is the science presented strong? What does that mean for the lung cancer community? And then, of course, I think the ultimate goal is to help patient research advocates identify research advocacy opportunities in their own countries. For example, being part of a grant review process, being part of a protocol review process. And with that, it is my privilege to introduce the 5 PRAs who were selected as the STARS advocates for this year. And this was a very, very competitive selection process. And 5 of them, as you can see, are from different countries. And 5 of them were selected from 35 applications that the STARS program committee received this year. And today you'll hear from one of the STARS program, one of the patient research advocates, Caleb from Nigeria. And with that, I'll turn it over to Dr. Stiles.
Great, thank you very much. My job's actually pretty easy. I'm really just going to echo Dr. Bunn. I think I was born in 1972 in Virginia when you had that first planning meeting, so I'll take that as a good sign. But I think for people hearing little bits and pieces of the press conferences in one little presentation, trying to put that into the big picture of what it means in lung cancer is sometimes hard. But echoing Dr. Bunn, the thing to really think about and grasp for the press over the course of this is the incredible progress that we've made in lung cancer. I give a talk to the medical students each year about lung cancer, and I look back at my 2013 talk, and the algorithm under stage 4 was chemotherapy, considered targeted therapy, that I had pulled out of a journal. And really there was nothing to talk about in stage 4. Where we are now, this is the treatment algorithm that was put out by a guy named Jordi Riemann, who's actually here in Barcelona, about the treatment paradigm in 2019. And look at all the different pathways where a stage 4 lung cancer patient could go. I'm not going to begin to try to describe that, nor does the press need to wrap their head around that. But wrap your head around the idea of going for chemotherapy, maybe targeted therapy, to all these multiple pathways in cancer. And that's really what the Ia SLC is about. It's really what all these talks and presentations over the next couple days will be about. And then the challenge for us and for STARS, though, is really telling this story through the patients and through the advocates like Caleb. How do we give them the language to talk about it? How do we go home and tell those stories to people to get them interested in the story of lung cancer and to understand the incredible science and the progress that's been made there? Patients have so many research touch points that it's critical that they understand and talk about it along the way as they go, and that's clinical trials. It's asking to give your tumor or give your blood for biobanking, joining advocacy groups, even participating in research funding panels. Every panel that I've been a part of that's had a patient or an advocate there as part of the decision-making process has been a better panel. And then it's meeting participation for meetings like these, but then really taking the story back home to your local cancer centers is really what we want to empower these patients and these advocates to do. And I truly believe that at every step of the way, patient participation and knowledge improves the process. It allows them to have ownership of the journey and to really be a part in the decision-making. I say it probably improves outcomes. I think all of us here know that it does, but we challenge the patients to take this data critically. We don't have a critical clinical trial that shows it improves it, but I know it does, and I know that they do. And importantly, it's going to help future patients. And then finally, telling the story through the patients, I think, will really allow the community to lobby for more research support for lung cancer, to bring it up to the level of funding for other cancers. And so with that, I'll introduce the real star of the show, Caleb.
Thank you very much. Before last year, I was a patient advocate, but for other forms of cancer, breast, cervical, and prostate cancer. And before then, I never knew that there was anything to do in terms of advocacy in lung cancer, because I felt, myself, like if you stop smoking, you wouldn't get lung cancer, so there's no need, for advocacy. But something happened last year when someone very close and dear to me, less than 30 years, never smoked in his life, passed on in just quick succession of just 2 months of diagnosis. And that took me down a path that's brought me to become patient advocates in lung cancer. This STAR program was created so that we could know more about the science of lung cancer. Last year was equally the first time I heard the word radon, and that it causes lung cancer. I've never heard about it, so I feel that this STARS program is something that is good, that would expose the patient advocates to learn more about the science in lung cancer. It will make, what the program would do, it will make us understand more about lung cancer and how to, during the course before coming for this program, that's before the conference, we had a series of webinars and conference calls. And they were taught how to interpret results. So before, if I go, to a conference and they're saying lots about the data and things, I was, be lost. But now with the program, I understand, when there's the p-value and things, in the presentation, and equally to understand more about research advocacy, like. For clinical trials, one of my interests, is in clinical trials, and there was a presentation that was shown to us today, and in clinical trials for Africa, there were just 9 clinical trials in Africa, whereas in the US, I think it was over 600 or so, and in India, it was just 15. So I think that this program would actually help us to drive more in terms of clinical trials, not just in the Western world, but in the developing world. And one thing about this society is that this society is truly global, not just focusing on the Western world, but they really want to reach globally. And what this program will help do is that it will help me to raise other advocates, because I'm a mentee now. In the next 1 or 2 years, I'll become a mentor. So I would actually be able to mentor other advocates in Africa, and actually, by the grace of God, maybe when we're back here in 1 or 2 years' time, the numbers will increase from 9 to maybe 15 or more than that. So thank you very much.
Thank you, gentlemen. I'd like to invite Matt Smeltzer to come to the podium to talk about the IASLC molecular.
Thank you. Good afternoon. A couple of disclosures. This survey was funded by AstraZeneca, and I have research support from the Bristol Myers Squibb Foundation. So we've talked about the significant advances that have been made in lung cancer. Dr. Bunn showed us, and Dr. Stiles had a nice graphic, and a lot of that has to do with targeted therapies and testing patients for molecular test is a key component to finding the right treatment. So with that in mind, the ISLC designed a survey internationally to try to evaluate how we're doing with molecular testing, how the physicians feel that we're doing, and understand it a little bit more. So this survey was distributed to ISLC members and healthcare professionals worldwide. We emailed out 34,621 specific links. We also made the link to the survey available through websites and other ways to share. The idea was to get as many people to respond to the survey as possible. We made it available in 7 languages, including English, French, Japanese, Chinese, Arabic, Portuguese, and Spanish, and we translated those into English for analysis and analyzed them all together. So overall, the survey, I'm going to show you a little bit about the survey. We had 108 questions, and we are looking at the frequency of testing, the current practices by medical oncologists and pathologists, and asking specifically about barriers to molecular testing in lung cancer. There was a general section of the survey that went to everyone, and then we had targeted sections for those clinicians involved in acquiring the sample, those involved in ordering the test, and then those involved in analyzing the sample. So you'll see throughout the results of the survey that some questions were specific to the groups, and then some were asked of all 3 groups. 2,537 persons responded to the survey from 102 countries. You can see we got a pretty good geographic distribution of responses. 56% of these responses were from developing countries, 44% from developed countries. Medical oncologists were the highest percentage of the respondents, but we also had good percentage of pulmonologists, thoracic surgeons, pathologists, and then scientists and other made up the remainder. 52% of the total responses were from Asia, 19% from Europe, 11% Latin America, 11% US and Canada, and 7% other. So some highlights of what we found. Of course, with 102 questions, there's some complexity here that we won't get into. But overall, most respondents report that they feel molecular testing rates in their country are less than 50%. However, when we ask specifically about their clinic, they feel they do more than 50%. When we asked specifically what conditions would prompt them to do molecular testing, they reported adenocarcinoma, never smoker, female and young. And then we got some specifics about what they test for and And in the pathology survey, there's a lot of nice detail that we look forward to sharing later. 41% of those who perform and interpret assays report that they're not satisfied with the state of molecular testing in their country. And they also, 17% of those felt that patients were not satisfied, 35% were unsure whether patients were satisfied or not. Some specific concerns that we pulled out from different questions, some of the physicians that request and treat patients report trouble understanding the results they get back. So about 37% cited that as a concern. The time it takes to receive results was mentioned in several places, and the reliability of the samples was questioned by some. We also found that 33% of all respondents were unaware of the most up-to-date guidelines for molecular testing from CAP, Ia Slc, AMP. And we also found this varied somewhat by region of the country, with Asia and the rest of the world having the lowest. Then we just asked specifically, what are the barriers to molecular testing that you face? And so we got some free text responses from the respondents. And so we broke that down and found the most common themes through all the free text responses. So overall cost is still cited as the most common barrier. Quality, access, awareness, and time were the next four. These five were the same top five barriers in each region of the world, but the ordering was a little bit different depending on region. So I think some regions may want to focus more in some ways versus others. So overall, we're still finding that many in the lung cancer community are not satisfied with the current state of molecular testing. We've got suboptimal awareness of the evidence-based guidelines. We have barriers that remain to molecular testing, which we've identified. And we're recommending continuous education around molecular testing and that it should be intensified on national, international levels to ensure that patients receive optimal therapy. So I think we can use these results to identify some specific ways that we can promote molecular testing more and educate more. So thank you for the opportunity. And I'd like to acknowledge our steering committee who have been wonderful in helping us dig through and interpret these results, and the Ia Slc and University of Memphis team.
Matt. And now welcome Jacek Jasem to discuss the Ia Slc Tobacco Declaration.
Good afternoon. Everybody knows that tobacco is the main cause of lung cancer and other malignancies, and also other diseases like heart diseases. But the question of whether smoking after the diagnosis is harmful is not, this problem is not recognized. That's why the Tobacco Control and Smoking Cessation Committee developed the declaration addressing this problem. The consequences of smoking continuation by cancer patients and survivors, cancer survivors, are multiple. First, smoking after cancer diagnosis increases cancer-related mortality and overall mortality. It increases the risk of secondary primary cancer, and there are many examples, not only in cancer patients related to tobacco smoking, but also other malignancies like breast cancer or prostate cancer and many others. It increases treatment toxicity, both surgery, radiotherapy, and systemic therapies. And of course, it is associated with much higher treatment costs, also due to the complications. So there are challenges and there are opportunities, and we addressed both. We realized that most smoking cancer patients persist in their habit during treatment and afterwards, and healthcare providers often don't proactively cooperate with their patients to help them to quit by providing tobacco cessation assistance. We have also data on that, some polls, some questionnaires, and we realize this is indeed an urgent need to increase this awareness. On the other hand, diagnosis of cancer is the teachable moment, allowing healthcare professionals the best opportunity to discuss with patients their nicotine addictions and shared decision making. So our opinion is that should be an enhanced focus on smoking cessation at the time of a cancer diagnosis, and active intervention may increase patients' action to quit. And here is the declaration. The first point, all cancer patients should be screened for tobacco use and advised on the benefit of tobacco cessation. In patients who continue smoking after diagnosis of cancer, evidence-based tobacco cessation assistance should be routinely and integrally incorporated into multidisciplinary cancer care for the patients and their family members. Third, educational programs regarding cancer management should include tobacco cessation training, empathetic communication around history of tobacco use and cessation, and utilization of existing evidence-based tobacco cessation resources. Fourth, smoking cessation counseling and treatment should be a reimbursable service. 5, smoking status both initially and during the study should be a required data element for all prospective clinical studies. And finally, clinical trials of patients with cancer should consider designs that could also determine the most effective tobacco cessation interventions. The whole Ia Slc Declaration is in the conference bags of all participants of this conference, is posted on the Ia Slc website, and will also be distributed by other channels. It will be present at all Ia Slc events, and we will also plan to contact other cancer societies to make this declaration available for all physicians. Thank you for your attention.
Jacek. Now to present on the Lung Ambition Alliance, I'd like to invite to the podium Giorgio Scagliati. The alliance was founded by a partnership through the Global Lung Cancer Coalition, Guardant Health, Ia Slc, and AstraZeneca.
Good evening to everybody. Tonight I have the privilege and honor to present you the Lung Ambition Alliance. As indicated before by Dr. Ban, we are a truly multidisciplinary society. We are the leading society in the field of thoracic oncology. We are doing a lot of projects. I personally believe that only through early detection of lung cancer, we will be able to significantly impact the 5 years survival of patients with lung cancer, in addition to the impact that already targeted therapies and immunotherapies had in the field. As part of our mission, we have a bold statement, if you have the opportunity to go back to our mission. And the third bullet point is say, Ia Slc will use any available means to eradicate lung cancer. Before eradicating lung cancer, we need to significantly improve 5 years survival and to cure a significant proportion of patients. So in the Ia Slc, almost 2 years ago, we started the discussion how to realize this kind of dream. And through a converging lines of evidence of scientific interest, the idea of the alliance was born. And just to explain you the dimension of the problem, well, every year 2 million of people are diagnosed with lung cancer. 1 out of 5 will be alive 5 years after the diagnosis. Obviously, we have a higher proportion of patients with early stage and a limited proportion of patients with stage 4. Is already the leading cause of cancer worldwide in male and females. And just to give you an idea, every minute, every single minute, 3 patients in the world, they are dying from lung cancer. So what we should do, obviously we can accelerate advances, we shape the environment, we improve the outcomes of people with lung cancer. And through the commitment of other founding members and some of the representatives of the other 3 founding members are sitting in the audience, and I believe that they are available for specific questions later on. The Lung Ambition Alliance is our commitment to tackle barriers to eliminate lung cancer as a cause of death. And this is a joint venture among ISLC, the Global Lung Cancer Coalition, AstraZeneca, and Guardian Health. These 4 entities are representing the founding members, and the ambitious program is to double 5-year survival in a reasonable time frame. How we can achieve that point or that goal? Well, we were able through a long-standing discussion among all of us to identify 3 pillars that are action point for today, for the future. The first one is to screen and diagnose earlier patients with lung cancer. And our commitment in these days is looking to implement as much as possible worldwide early detection of lung cancer through CT scan screening. Because today we have already 2 positive studies in the field, and there is time to move forward. We have a specific program, a specific quality program to assess the nodules that are detected to the CT scan screening studies, but we would like in the near future also to disseminate the idea that the CT scan should be offered to the high-risk subjects. Obviously, we are using new technology, including liquid biopsy, and especially in the follow-up of the patients who were radically resected and they went to the resection through early screening, there is an opportunity to follow this type of patients. We are also looking to deliver as soon as possible innovative medicine, and probably in the near future, Dave, myself, and also Tetsuya we wrote an editorial in which we were saying that probably we need to learn how to implement, how to integrate systemic therapies in the management of early disease, and how to implement local therapies in the management of stage 4 disease. And this is leading me to not only to the early stage management, but also to a better understanding of the mechanism of resistance and to identify new clinical endpoints. And finally, we need, as other speakers today already referred on, we should look how to enhance the quality of care, and this is a specific pillar that is under the leadership of the Global Lung Cancer Coalition. Obviously, there is still a missing point in this slide, because there is an horizontal pillar that will embrace the 3 other vertical pillars, that is smoking cessation. And we need, as Dr. Jacek Jasen was referring before, we need to do more in the field of tobacco cessation. Well, what the Lung Ambition Alliance is doing during this meeting, obviously we have a booth, and these 3 pillars, I skipped the slide for reason of time because it's already 5:10, but we have a specific booth in which you can get additional information about the Alliance and the initiatives that are under the leadership of the Alliance. Just behind this wall, You have the opportunity to see the mobile CT scan track. In the center of Barcelona, in one of the major squares, we have these big cigarettes that the program has been initiated by a European advocacy group that is called Valce, and the English title of the program is Don't Burn Away Your Future. And finally, there is this announcement about the ILC2 initiative, that is an initiative in lung cancer care, again, as I said before, under the leadership of the Global Lung Cancer Coalition. If you want to understand more about the Lung Ambition Alliance, you can refer to the specific website that you see at the bottom of the slide, www.lungambitionalliance.com. Thank you so much.
Thank you, Giorgio. Thank you.
Thank you. Christine Clark, United Kingdom. I'm not quite sure who to address my question to. It would be Dr. Stiles, Dr. Roy, or Mr. Gueno. But could any of you tell me a little bit more about the background of the people who take up the STARS program? Are these healthcare professionals, or are they coming from other backgrounds? I'd just like a little more.
Thank you for that.
The 5-star mentees who are selected, the patient research advocates, they're not healthcare professionals per se. They've all been impacted by lung cancer or cancer in general, and they've been advocates for a couple of years, so they are seasoned advocates. And the STARS program was developed to help this group of people become more research-focused, more research advocates.
Question here.
Pam Harris, Medscape, Canada. Are the smoking rates coming down in Europe? Because in Canada, I believe our smoking rates are actually quite low, especially in BC and places that are more enlightened than other provinces. But just as an observer in Europe, I mean, I can never get over how many people smoke, especially young women.
Jacek or Giorgio, would you like to take that question?
I need to understand, because I cannot hear anything from here.
You can't hear that?
No, I cannot hear anything.
The question is smoking rates in Europe. Are they going up or down?
If you are looking to what lung cancer in Europe is doing, lung cancer in Europe is an alliance of different advocacy groups, and they did a nice survey across several European countries. There are huge differences, and I'm trying to be politically correct. I'm just referring to the numbers, okay? In Scandinavia, in some of the Scandinavian countries, there is a significant impact on lung cancer mortality from the public health measures that they made several years ago. We see, for instance, in Italy, we see some decrease in the incidence of lung cancer in males. Unfortunately, we don't see any change, or paradoxically, there are some increases in, let's say, mild increases in women. What is pretty dramatic, there are countries, I'm not referring to all the countries in the Eastern European countries, but some of the European countries in the East Bloc are still suffering from a significant mortality rate, and also in terms of incidence rates for lung cancer. I would say that there are still huge geographical differences in Europe. In those countries in which clear restrictions in the public setting has been done about tobacco use. We started several years ago in stopping through laws, obviously, not because we decided ourselves, to allow tobacco smoking on the public transportation means, and then we restricted also in the restaurants and the bars. Well, we still see a lot of people standing outside of the buildings smoking tobacco cigarettes. Sorry, but it was impossible to understand the question. The noise is pretty.
To give a talk. He's not avoiding the press. Are there any questions here in the front?
Hello, I'm from China, 医学界. I'm Yongki, and as tobacco is the major hazard reason for lung cancer, especially in China, and China has perhaps the highest rate of male smoking rate, about 55%. Also the highest number of smokers in the world, and also we might have more second-hand smokers, especially especially women and children. So this phenomenon might have something to do with our policy and our tobacco selling mechanism, which is controlled by government. So I'm just wondering, would IASLC help us with this tobacco problem? And besides the education, what are the other approaches that we can do, for our people? Thank you.
Jacek, would you like to take that from a smoking cessation committee point of view?
This is, ISLC is a clinical society, but we are not only dealing with diagnostics and therapy of lung cancer, but also with prevention. So what we do, the primary prevention is mainly anti-tobacco activities. And our committee is very active in this area. We have many undertakings. Declaration is one of the examples, but we have many publications, many other scientific work, many media meetings. We are advocating anti-tobacco policy over the world. Of course, we have no time here to talk in details about this, but this is, I believe, one of the most active committees within the ISLC. So I will be happy to give you some more details. I am also personally involved in the activities in China. I contributed to the translational lung cancer research, a very rapidly developing Chinese journal. With these topics, I think I published 3 articles on the tobacco issue there, and of course we've done much more in other publications. But in 2019, there was a special issue published in the translational lung cancer research devoted to primary and secondary prevention. So you can learn much more there.
Thank you. Other questions from the press? Again?
Thank you. I think this is a question for Professor Scagliotti. My understanding is that the number of people and the proportion of people who have cancer who have never smoked is increasing in Europe as the number of people who have smoked and have developed cancer is falling. How does that fit with your ambition to reduce the incidence of cancer? What can you do for people who have never smoked?
Well, it's true that the proportion of never smoker patients who are getting a diagnosis of lung cancer is increasing. But from my point of view, it's a completely different disease. and the vast majority of the patients are still heavy smokers, okay? So it's a nice story. You know, in all these kind of meetings, we can tell you this nice story about targeted therapies, but if you want to impact at the level of the population, you need to address the patients with a cancer that is caused by tobacco smoking. Because it is true that, let's say, there are geographical differences. In Italy, it's only 18%. In Asia, it's more than 30%. I believe that in the United States or in Canada, it's only roughly 20%. We have therapeutic opportunities. Remember that we can already extend survival of 4 to 5 times compared to what we did 15 years ago for these patients. In the younger patients below the year of 40, it's a completely different disease. At this meeting, there is a poster, if I remember correctly, about the genomic assessment in those patients who were diagnosed with lung cancer below the age of 40. And 33%, they had, let's say, I'm not sure about, it could be 32 or 34, you know, in the range of 30%, they say, people who are politically correct. 30%, above 30%, they had a ALK rearrangement. We have multiple therapeutic choices, and we are able to extend survival up to 5 years for these patients. Obviously, it's not true for every individual patient, but at the population level, we are, at least for what we got through clinical studies, that is not true for patients who are heavy smokers, and we need to do something also for them. I'm not forgetting this 20%, but this 20% at the same time is a sad and nice story to tell, because obviously it's a sad story because you are making diagnosis to people who are pretty young. And believe me, at the clinical level, it's really a struggle, because it's a struggle for every one of us. But at the same time, in the vast majority of the cases, you can offer them a therapeutic opportunity through targeted therapies.
Is this microphone working?
Yes.
I'm sensitive to the idea of never smokers as well. We wrote a paper 2 years ago looking at the proportion of smokers and never smokers. In our most recent time period, 29% of our surgical patients were never smokers. That doesn't necessarily mean that those patients are increasing. Maybe there's just less smokers, and we need to look at a more global population to understand that. But the real irony is that most of the patient advocates out there are the never smokers. They're the vocal ones. They're the ones with these incredible success stories on targeted therapies. Where we need to do a little bit better is to embrace those other patients who were smokers, who feel stigmatized by the disease, who aren't as likely to come out and to talk about it. And that's a real struggle in the community. And if you take something like screening, there's a real vocal group of never smokers that want to do, hey, what are you doing about us for screening for lung cancer? Really, we have to win the screening in the smokers first, in the very narrow defined population where we can, and we need to get the never smokers behind it to win it there. And then undoubtedly we'll find blood-based biomarkers or other risk factors that will then be able to extend screening to never smokers, and we'll do better with everybody else. But I completely agree we need to start with the smokers and do better there.
Thank you for that. Other questions from the press? Good. All right, well, thank you for your time. Thank you to the panelists for sharing the highlights of these programs and for taking the questions.